Colorectal cancer, an overview. Agenda. The agenda for this discussion includes: what is colorectal cancer or CRC? Prevalence of CRC, ACS recommendations for CRC screening, conventional screening tests for CRC, advanced screening tests for CRC, the role of diagnostic markers, tests offered by Metropolis for CRC, a summary of the topics discussed. What is CRC? According to the Centers for Disease Control and Prevention, colorectal cancer or CRC is a disorder characterized by uncontrolled cell proliferation in the colon and rectum. Polyps or abnormal growths that form in the colon or rectum can sometimes progress to cancer. According to global cancer statistics, CRC is the third leading cause of death among cancer patients. Screening helps to find the polyp at an earlier stage and thus it can be removed, preventing it from turning into cancer. Early screening also helps in planning an effective treatment strategy for the patient. Prevalence of CRC. In recent years, the prevalence of CRC has been on the rise worldwide. As a result, 1.93 million new cases of CRC and 0.94 million deaths, that is 5,15,637 deaths among males and 4,19,536 deaths among females from CRC were reported in 2020 globally. That indicates 10% of the global cancer incidence and 9.4% of deaths. According to 2020 Globocan estimates of colorectal cancer in India, the incidence of colorectal cancer among males was found to be 6.3%. On the other hand, the incidence of colorectal cancer among females was found to be 3.7%. American Cancer Society of Colorectal Cancer recommendations for CRC screening. Adults with average risk of CRC aged over 45 years should undergo regular screening with either a stool-based test or a visual examination, depending on patient preference and test availability. All positive results on screening tests other than colonoscopy should be followed up with a timely colonoscopy. Various recommendations for CRC screening include: to begin CRC screening at age 45 is a qualified recommendation. Regular screening in adults greater than or equal to 50 years is a strong recommendation. Average risk adults in good health with a life expectancy of greater than 10 years to continue CRC screening through the age of 75 years is a qualified recommendation. Clinicians individualizing CRC screening decisions for persons aged 76 to 85 based on patient preferences, life expectancy, health status, and prior screening history is a qualified recommendation. Clinicians discouraging individuals over the age of 85 years from continuing CRC screening is a qualified recommendation. Conventional screening tests for CRC. Various conventional screening tests for CRC diagnosis are: physical examination. Colonoscopy examines the inner portion of the rectum and the colon of a patient under sedation. This accurately identifies the location and spread of the cancer. In a biopsy, a small amount of colorectal tissue is examined under a microscope. This is essential for the definite diagnosis of CRC. Computer tomography or CT scan, magnetic resonance imaging or MRI, ultrasound and positron emission tomography or PET scan are all methods for detecting cancer spread. Advanced screening tests for CRC. Various advanced screening tests for diagnosing CRC include: identification of specific gene mutations helps in the definitive diagnosis of CRC. Capsule endoscopy involves the patient swallowing a pill-like capsule that contains a tiny wireless camera that clicks pictures of the digestive tract and transmits them to a small recorder. The pictures are viewed on a computer to check for signs of disease. Testing for the circulating tumor cells released by cancer cells. Small molecules called metabolites may be detected in urine that show the presence of colorectal polyps and tumors. Role of diagnostic markers. Among the various biomarkers for CRC, the most important ones used as prognostic and predictive factors are Kirsten-Rath sarcoma viral oncogene homologue or KRAS, BRAF murine sarcoma viral oncogene homologue B or BRAF, and microsatellite instability or MSI. KRAS is the gene that undergoes dominant mutation in CRC, while it also helps to detect the heterogeneity of CRC and anti-epidermal growth factor monoclonal antibody resistance. BRAF helps identify specific phenotypes and metastases in CRC and assess the resistance to anti-EGFR monoclonal antibody. Finally, MSI assesses the resistance to 5-fluorouracil. Currently approved first-line drugs for the treatment of CRC are cetuximab and panitumumab. As second-line therapy for CRC, combination of drugs are used which includes folinic acid plus 5-fluorouracil plus oxaliplatin, folinic acid plus 5-fluorouracil plus irinotecan hydrochloride, capecitabine plus oxaliplatin. Tests offered by Metropolis for CRC. The different tests offered by Metropolis for accurate diagnosis of CRC include histopathologic examination of colectomy or APR KRAS mutations, special stains and reflex immunohistochemistry or IHC, KRAS 12 or 13 mutation analysis, extended RAS testing that is ColoCheck, mismatch repair IHC reflex to microsatellite instability polymerase chain reaction or PCR. All these tests have a turnaround time of 7 days. Summary: CRC is characterized by the uncontrolled growth of cells in the colorectal region and is the third leading cause of cancer death. According to global cancer estimates, the incidence and death rates of CRC are on the rise. KRAS, BRAF, and MSI are vital biomarkers for diagnosing and assessing the prognosis of CRC. Metropolis offers a panel of tests for a definitive diagnosis of CRC. Thank you.